Well, folks, we'd like to welcome you to our first webinar here at the EMS division at Maine Medical Center. Our speaker will be joining us in just a brief moment, so we want to take an opportunity to wish you all happy EMS week. Beside me is Dr. Scholl.
Everybody, happy EMS week. Maybe first, while we're waiting for Jack to join in, he's just bringing his slides up and getting pulled up on Teams. He tried to join us remotely and needed to come into the office to actually make it on Teams. But maybe, Eric, we can talk a little bit about what this meeting signifies and what this meeting is all about.
Excellent. Yes. So this is the beginning of a monthly series of topics that we'll be doing for providers. Just a 1-hour webinar where we pick specific topics to discuss with you and go over. Our residents will be joining us, and some of our attendings and various other providers in the area. And I believe our esteemed colleague Jack has joined us.
Yeah, while he's getting ready and pulling stuff up, I just want to thank some of our residents, in particular Joe Minichello, who brought this idea to us and was really excited about helping get this going. You'll be meeting him in the coming months if you come to some of the upcoming meetings. But we're really excited about this because this was an idea that our residents and Jack and a couple others really rallied around, and we're hoping that this becomes meaningful to everyone else. So why don't we turn it over to Jack? And with that, happy EMS week. We're really super excited you all joined us. If you have any questions or would like to reach out to any of us, please do so. And Jack, there you go.
Hey guys, can you hear me okay?
We can.
Okay. Let me just do this real quick. How's that? See my slides?
Yeah. Looks great.
Awesome. Sorry for the delay as Microsoft Teams continues to be fun for us. So my name's Jack Lewis. I am currently the EMS fellow here at Maine Med. I've been working with the Portland Fire Department and Lifeblood Maine for the past year. This is our first year of the fellowship, and we are more than glad to talk about that at some point during the next hour. But I'm going to get right into a talk that I call Advanced Basic Airway. And I tried to come up with an organized approach to airway management for all pre-hospital providers. And certainly as we go along, Eric, I'm not sure, do they have the ability to put questions in the chat that we can kind of save and come back to?
They do. If anybody does have any questions, please throw them in the chat at any time.
Sweet.
The Q&A section or
Awesome.
the chat.
So I have no disclosures. I'm still very poor. If you would like to give me disclosures, happy to accept them. But let's talk a little bit about kind of the basics of airway management. So this is what we like, where we learned about airway, right? It's anesthesiologists really are the ones who have pioneered the world of airway from the beginning. And that was in the world of emergency medicine. We would learn from them. We would adopt their techniques. In the world of EMS, that's, where you go to learn about how to manage airways, where you do some of your first real human intubations, where you learn how to do bag masks. But this that you see on the screen, that is not the environment that we work in, right? Like, this is the environment that we work in. It is an entirely different setting. It is an entirely different patient population. And it is an entirely different set of coworkers, right? Like the circumstances under which we are attempting to do the same things are dramatically different. So the question becomes, how do we consistently and expertly manage airways in difficult environments? And I think we've done a good job of teaching this, but I think the way that I've kind of broken it down in my head is that the first step is that we really want to have expertise with our basic airway maneuvers. Once we have that basic expertise, we should probably have some game plans for certain situations, right? And we can go through what those are. And then As the last piece of this puzzle in this talk, I want to introduce the idea of checklist to you as something to kind of ponder and think about. So, what are the techniques that we need to stabilize and assess and buy ourselves time whenever we're managing an airway in the pre-hospital environment? Except for sometimes when we know we're going to have to do kind of something different. And then once we have gotten there, what's our routine? How can we cognitively offload some of the more difficult things that we're expecting of ourselves and of our providers in our system to do? And how can we do that better? So first, let's go over some basic airway maneuvers in anatomy. Um, Eric, are you able to see my pointer at all? Probably not. Yeah?
Yes.
Yep.
Okay. So this is a cross section of our upper airway, right? And what happens when we take a breath in a normal human, normal day, is that you have muscles that contract, allow the soft part of your tongue, the soft part of your palate to open up, get air through your nasopharynx, your oropharynx, and then pass through the trachea, right? You have a negative pressure that starts in the chest, and then you're using muscle contraction to create that space. In the setting of a patient who's not able to use those muscles, who may have weak negative pressure because of their altered mental status, this all starts to fall apart. The soft parts of the tongue and the pharynx start to collapse back on each other, potentially even collapse back into the pharynx here. The pressure is not going to be strong enough to draw the air through that narrowed space, and you will have increasing difficulty getting air to pass through the right holes into the trachea and not down into the esophagus or not into the body at all. So the first thing that we can do to start helping with this is positioning. So imagine, if you will, you show up and you see our friend here who's having some difficulty breathing. He has a lot going on in terms of difficult airway anatomy. He's got a large chest wall. This is going to be a difficult airway, and you can tell that before you even get close to him, right? And one of the first things that we can do is help put our patient in a position to be able to breathe better. One of the tools that we have to do that is our stretcher. Even as soon as they're on the stretcher, you can start manipulating that equipment so that their head is up, probably at least 30 degrees, maybe even more. And once you get the head of the bed up, not only are you offloading some of that chest wall, which is going to help them to be able to take their breaths with good chest rise and chest fall, but we know that elevating the head of the bed in the controlled environment of the operating room can help with preoxygenation. And we have a lot of studies that show this. There's one that showed that there wasn't any difference in young, healthy volunteers in a supine position, like in a super controlled environment. But that's just kind of a negative study where we've got all this other evidence that shows when we bring up the head of the bed, we can start to get more oxygen from outside to inside of our patient's lungs. And that is the most simple thing that we can do to start managing an airway, is just getting the head of the bed up, elevating the head of the bed to some extent. Next thing that I want you to think about anytime you enter the realm of the airway is suction. In patients who are no longer able to maintain their secretions or manage their secretions, you should just do it, right? This isn't complicated. Uh, the only time it may become complicated is if you're more aggressively suctioning and potentially stimulating a gag reflex. But suction is an integral part of basic airway management. And it's one of the first things that if I'm preparing to manage an airway in the emergency department or in the back of an ambulance, I want to make sure that the suction is on, that it's working, that I can get suction at the distal tip of the catheter, that there isn't a disconnected hose, that it's not a Yankauer that has one of the holes that you have to occlude on the top of it. just have your suction ready and know how to use it. There are fancy suction techniques, such as the salad technique, which is the suction assisted laryngoscopy and decontamination. I think I got that right, Matt? I think those are all the letters. But the idea is that if you are going to manage a heavily soiled airway and are doing laryngoscopy, not only are you going to lead the tip of your laryngoscope with your suction catheter, but you may go so far as to park your suction catheter in the esophagus of the patient, shift it over to your non-dominant side, and then continue on with your intubation with that suction implement in the patient's mouth. It's a whole other talk, and we're happy to follow up on that and talk to you more about silo technique, but just know that suction is going to be a big part of any airway management. The next thing I want to talk about is jaw thrust. So let's go back to our picture here. We've got tongue, soft palate. Then we've got the epiglottis right here. And you can see that the epiglottis has this little ligament attached to it that goes to this little structure, which is the hyoid bone. And the hyoid bone is one of the only free-floating bones, kind of like the kneecap, in the body. And the hyoid bone is connected with some other ligaments to the mandible or the jaw. And when we look at this, when the way that doing a jaw thrust works is that you take the mandible here, you displace it forward. That pulls on the soft tissues. Not only does it help the soft tissue of the tongue kind of come away from that soft palate, but it also helps to pull and distract the hyoid bone and pull and distract, in sequence, the epiglottis. And it helps that epiglottis to open up, come away from the back of the pharynx, and then allow air not only to pass through the oropharynx, but then also into the trachea and not down the esophagus in the back, which obviously is less than ideal. And so this hyoepiglottic ligament becomes kind of a big deal, and its connections with the jaw are something that I want you to remember. The hyoepiglottic ligament, and we can talk about this in a different talk about laryngoscopy sometime, is something that you can actually see. If you have a really good view of your epiglottis, there's a little line in the middle, which is the hyoepiglottic ligament, and engaging in that and distracting that anteriorly helps to get that really good view during laryngoscopy. So what happens with jaw thrust? Well, just like I was saying, you take your mandible, it's connected with soft tissues and ligaments to the hyoid. In absence of that, in your supine patient, those soft tissues can collapse, the epiglottis can close, and you'll have a patient who is difficult to ventilate. If, however, you manipulate that jaw with either jaw thrust, head tilt, whatever it might be, but anteriorly distract that mandible, you're going to pull on that hyoid, which is going to pull on your epiglottis and allow air to pass much more easily through your trachea. So this is a cool video that shows what that looks like on the inside when you're doing jaw thrust. So what you see right now, before I start the video, is a endoscope that is looking at the epiglottis sitting in the pharynx. And what they're going to do is the person at the head of the bed is just going to do the jaw thrust, and we're going to see the result of what happens to that soft part of the airway in the epiglottis. So, in absence of a jaw thrust, soft tissues are collapsed, epiglottis is hanging over the opening of the trachea. You do jaw thrust, and everything opens up, right? You're distracting those tissues anteriorly, you're opening those passages, and it's just that much easier to get air from the outside to the inside. But that was a pretty cool video. So what's another way we can do that? And maybe arguably the best way that we can do that is sniffing position. So sniffing position is just what it sounds like, right? We are taking the external auditory meatus and lining it up with the sternal notch, or bringing your ear hole to your neck hole, flexing the cervical spine, extending the occiput, the OA joint, and moving all of your airway accesses into the most inline position. So the idea is that in sniffing position, by bringing this external part of the ear up to the sternal notch, trying to get that in line as much as possible, you are lining up the oral axis, the pharyngeal axis, and the laryngeal axis, the one that actually goes through the cords, as much as we can. And not only does this help obtain views in laryngoscopy, but this makes it easier to move air during basic airway maneuvers or bagging the patient. And this is as simple as, like, the way I always teach is just get the ear hole to the neck hole, right? Like, you've got that little depression in your suprasternal notch. You get the ear up to that point and you're achieving sniffing position. And this is kind of that quintessential study that did MRI and they identified I believe the mouth access is MA, pharyngeal access is PA, and then laryngeal access is LA. And what you can see is that moving from neutral versus head lift versus just extension, when you put a patient in sniffing position, all of these lines come together as much as they're ever going to. And they talk about a two curve theory, but the idea is that not only is putting a patient in sniffing position helpful and optimal, this paper argues, for direct laryngoscopy, but it should be applied or could be applied to any sort of airway maneuver and maintaining good airway positioning. And there is definitely some argument about whether ramping or sniffing is better, but we don't have definitive evidence that a ramped position, so bringing, the shoulders and the rest of the kind of the head, neck, and torso up, is not necessarily better or worse than just sniffing position alone. But we do know that sniffing position by itself can help to open up those upper airways and decrease obstructive processes when patients are unconscious and trying to breathe. So we've positioned, we've suctioned if we need to. Now let's look at a couple of actual adjuncts. And we know we've got our OPAs and our NPAs. We have all been classically taught. We'll talk about OPAs first real quick, right? You measure from the corner of the mouth to the corner of the jaw. That's the size of your OPA. You put it in either sideways or direct, however you want, and you've opened your airway. One thing that I just want to mention when using OPAs is that this isn't, this isn't like very sexy. This isn't something that's studied a lot. There's not a lot of controversy around this. But there was one kind of interesting Japanese study where they looked at what is the best way actually to measure our OPAs? And so they were in the OR and they were ventilating patients and they had two OPAs. One they measured from the corner of the mouth to the corner of the jaw, and the other one they measured from the incisors to the corner of the jaw. And their question was, if we kind of like oversize this OPA, are we going to get less obstruction when we're mechanically ventilating these patients in the OR? And so what they found was that those slightly larger airways helped to they said that they were more advantageous than the others, which basically meant in their study there was less resistance, there was more airway patency using the slightly larger OPA. So I think what I want you to take away from this is not that we should be measuring from the teeth for all of our OPAs, but if you're not sure exactly what size OPA to be using, upsizing, between the two options probably isn't going to do you any wrong and will probably be just as effective if you are in a tight spot. Then we've got our nasopharyngeal airways. And I love NPAs because these are a little bit better tolerated than the OPA. The OPA will trigger that gag reflex kind of at the base of the tongue, whereas the nasopharyngeal airway actually really bypasses it. It doesn't come into contact with the base of the tongue and where the nerves are that stimulate that gag reflex. And you can have, it's uncomfortable, but you can have an NPA in a perfectly awake patient. The trick with NPAs, in addition to sizing them correctly, is making sure that you're going to be putting them in with the right orientation. So we all know that our nose holes look like they go up, but actually, like you can kind of see in that last diagram, our nasal passageways go straight back. They are anterior to posterior. And that is how we should be directing the insertion of our NPAs and really anything that's going into the nose. One of the reasons we do that is because in patients who have head trauma, there is that risk of having those NPAs take a little misadventure. And this is something that I think we've all heard about in our EMT or paramedic classes, but this actually happens. I've been giving some version of this talk for a little while, and the last year when I went back into the research and looked up if there were any other cases, I was able to find 5 different case reports of intracranial nasopharyngeal airway placements. And the reason that this happens is that the little area that is at the so this is the nasopharynx. It comes through, there's turbinates here, and then your olfactory nerve sends down little shoots through the bony part of the skull in that area called the cribriform plate. That's what you see here, which is this like spongy looking area. And this is just not a robust part of the skull. And so if you have an insult to the skull, if you have a concern for a basilar skull fracture or a major facial trauma, the concern is that when you take that, probably it's been sitting in your ambulance, is cold and hard rubber nasal pharyngeal airway, stick it up, through the nose hole into this weak bony plate right here, that can go through and puncture that more vulnerable part of the cranium. So just be aware that the cribriform plate is the concerning part of the skull when placing an NPA, and that there's a relative contraindication in head trauma or facial trauma when placing a nasopharyngeal airway. I don't think that we should do it routinely. We've all been taught that that's kind of a no-no. But if you are aware of the risks and the appropriate way to place them, and you're not doing it against resistance, it's certainly not an unreasonable way to manage an airway, even if there is some remote concern of head trauma. And if one is good, more may be better. There's no evidence that this is some company called Real First Aid is calling this the silo or the rocket technique. I could not find any evidence that this improves ventilation relative to just one appliance, or this has not been studied. But be aware that if you are having difficulty ventilating your patient and you are concerned that is upper airway obstruction, and you are working at it from the basic level, there is no problem in placing multiple adjuncts to manage your patient's upper airway. And I don't think you'll catch flack if your patient comes in looking like this and is being adequately ventilated. I think that's the biggest takeaway, is that we want the patient to be ventilated as well as possible. So let's talk about that briefly, BVMs, and how we manage that kind of moving slightly from A to B, the basic maneuvers of bagging someone. I think one of the biggest things is knowing your equipment, knowing how to use it, and being comfortable with it. And I think that we always want you to have 2 people when at all possible to be doing this procedure. And I think you should kind of think of it as a procedure, because this is not a benign uh, thing to be doing to someone. Not only can we not effectively ventilate them, which obviously becomes a problem, but we can also ventilate the stomach, which does not help with oxygenation and then potentially makes them throw up in just a little bit. So when you are working on bagging a patient, one of the most important parts is getting a good mask seal. And I think you should, whenever possible, be using 2 hands to be doing this. We've all learned the EC grip to be doing it from the back. But if you're doing it from the front, you can do something similar, and you can use the thenar eminences, so the kind of beefy part of your hand and thumb, to get a good pressure down on the mask from the front of the patient, from the inferior, aspect of that face, and still get a really good BVM seal with 2 hands. There's all sorts of special patient populations who are difficult to bag. So one is the edentulous patient, or someone who doesn't have any teeth. In this one study that I found suggests that in the edentulous patient, you might use the bottom part of that bag valve mask to kind of displace the bottom lip a little bit to help bypass that soft tissue right at the entrance of the mouth, and be able to move air more easily in that way. And then there's a whole host of, this is just great. This is anesthesiologists having fun talking about beards, and, overcoming the beard, a close shave, really bad puns. But the idea is that even those who are um, doing this every single day, bagging patients very routinely in the operating room, it is always a discussion how to manage somebody with a beard. And so they suggest all sorts of different things, whether it's a Vaseline, large tegaderms, saran wrap. Just know that bagging somebody with a beard is likely going to be more difficult. And it's not just you, it's everybody, including anesthesiologists for the past 30 plus years, right? So have a plan, be thoughtful about the way that you're managing these patients' airways, and know that that might be a little more difficult. With all of my talks, I try to like take you up to what you know and just a little bit past, so that you're kind of aware of interesting things that are not that are just kind of ideas that are not necessarily routine practice. But one of the things that I found that I thought was really interesting and that I'd never heard of is that there are people who are advocating for rotating the head during bag valve mask ventilation. And their contention is that when you rotate the head, you increase the cross-sectional area of the upper airway, which not only helps to kind of distract those tissues in different ways and improve the upper airway patency, but also, opens it up more so that it's easier to ventilate. You get reduced upper airway obstruction and improved tidal volumes in paralyzed apneic patients. They studied this. They, in the OR, they had a flow sensor to see how much flow and volume they were getting into patients, and they would manage their airway in the typical heads on, like straight on position. And then they had a little protractor rotated 45 degrees. And what they said is that they significantly increased the efficiency of BVM, as opposed to like when they're rotated as opposed to when they're neutral. Do I think that we should rotate the head of everyone who we're BVMing? No. Do I think if you are in a really tight place and need to try every possible trick in the book, that doing a little bit of rotation with your bag valve masking might be helpful? I'm not sure. I can't say that I've done this, but it's kind of an interesting concept that I thought you might also find interesting. And let's just touch on real quickly the whole question of volume. So how much volume is in one of these bags, and how much should we be giving? Well, the average adult tidal volume, we always say is kind of around 500 mLs, and these bags have a whopping 1,500 mLs of air in them. And so we know that hyperventilation is a real problem. We've all seen it. We know that it's part of the high quality CPR, that we should be avoiding overventilation. And uh, I don't know that there's a perfect answer here, but I think it's worth talking about. So we've had studies that look at, if we change the way that we hold the bag, does that optimize the volume that we deliver? Uh, or um, especially in compare this study looked at doing it in comparison to a pediatric BVM, which just has a smaller volume to start with, and they found that it is possible to get people to change their grip, but when they used a pediatric BVM, there were more consistent volumes that delivered. And I don't know that this is a realistic or important thing to be doing, like to just only use a pediatric BVM. But I do think that we should be very aware of how we hold our bag and how our providers on our scene helping to manage our patients are holding the bag. So if you see someone on your scene on the right here, I would try to get them to change what they're doing, use a couple of fingers, look for that just visible chest rise, um, and really be cognizant of how much volume we're delivering to patients, because making them, uh, you know, tachypnic, hypocapnic, is not going to be doing us any favors, particularly in head injured patients or in patients in cardiac arrest. So that's a lot. That's kind of the bulk of the how do we do the basic things really well. Um, so let's move on to the next kind of category, which is game plans for certain situations. So when can we cognitively offload or just stop thinking about how we're going to manage the airway and just know that we're going to do it a certain way? The first time that I think about doing this is in cardiac arrest. And we have had a lot of studies that look about how to best manage a patient's airway in cardiac arrest. We've looked at intubation versus supraglottic airways. We've looked at supraglottic airways versus BVM, every combination of these things. And what we consistently find is that there isn't necessarily a best answer. The studies go back and forth. So this study found that uh, which one is this? The laryngeal tube had better outcomes than intubation. But then we also find that there isn't any favorable outcomes when you compare supraglottic airways to intubation. And then in the past year, you might recognize a name on here, with Matt kind of being part of this group that looked at all of the evidence from all of the pre-hospital literature that we have. And what they found is that BVM is always a good place to start, and supraglottics should probably be considered the first airway modality, but it's just because intubation is hard and we don't have real definitive evidence that intubating patients improves outcomes relative to supraglottic airways. And that's even more true in the pediatric population. There's the classic Gaucher study that found that BVMs were superior to intubations. And our colleagues in the pediatric ICU are now routinely recommending primarily using supraglottic airways to manage these patients before they're here at the tertiary care center. And I think it's really interesting because what it's telling us is that we don't have to work harder, that we can just kind of work smarter, right? And the way that I implement this information in my own practice is I just start with a supraglottic airway. I don't need to overthink it. I don't need to worry about setting up for intubation immediately. I don't need to BVM for a certain period of time. I just know that a supraglottic airway is probably going to work. And if it doesn't work, then we can troubleshoot. because I know BVMs are effective and are a good starting point, and I'm going to need some time to set up my intubation anyways. So for me, one of the ways that I can have a game plan is that if I'm going to a cardiac arrest, I'm going to ask that we just drop a supraglottic airway and don't worry about it for a minute. Once we kind of get rolling, we can move to intubation. That's fine. That may be the most appropriate thing to do. But to get started, to get our feet underneath us, I always like to start with that supraglottic. And this is kind of outlining all of those reasons. Intubation is hard. It's not easy to do. You can do it with continuous CPR, but it's difficult. And if we're bagging someone, we should be taking those pauses. We should be doing 30 and 2, but we know that no one ever does 30 and 2. That's just not what happens. So when else can we just kind of know what we're going to do with an airway? When do we not have to really think through an algorithm? Um, One of the times that I think is kind of important is with asthmatic patients. So there are certain patient populations who we want to avoid advanced airway management if at all possible. So asthmatics, for example, they've got an obstructive process going on. Their primary problem is that they can't get their CO2 out. Those airways are clamping down. They may be able to breathe in and get some oxygen in, but exhaling and really ventilating out is their primary issue. So if you move to an advanced airway with them, you're restricting the caliber of the passageway to get the air out. You're moving them to a positive pressure system, which is going to preferentially put more air in and make it more difficult, or at least slightly more difficult, to get their air back out again. And so there are patient populations where we really should say, okay, everything basic, we're trying to avoid intubation if at all possible, and we're trying to avoid positive pressure if at all possible. There are also certain populations where we really need to think about cutting the neck early. So facial trauma, I think, is one of the more obvious ones that we've thought about. Burns are another really important one. Burns to the face can not only cause the local edema that can cause those airways to close, but we can have inhalational injury that affects the airways that we don't see. And we should have a really low threshold to be reaching for that scalpel before delaying time to manipulate, disturb, make worse the upper airway, and then have those patients crash on us. And then obviously other forms of edema, if you catch like a late angioedema or anaphylaxis, obviously you want to be considering the neck very early in your algorithm as opposed to moving through our basic procedures first. So we start with our basics. We buy ourselves time. We know how to do that really well, except when we don't, except when we know we're going to look to the neck or look to do a supraglottic. Now let's talk about checklists for just a minute. Back in the late 90s and early 2000s, there's a big movement towards using checklists in healthcare. And some of it stemmed from this book by this guy named Atul Gawande, who's a surgeon. And his whole thing is that being a human providing medicine is really difficult. And we are fallible. We make mistakes and we work in a difficult environment. So, how can we have a tool to help us do better? And one of those tools is a checklist. And the idea is that even if we like even if we know the stuff, it's applying that stuff in the circumstance that becomes the problem. And to do that better, we can make a checklist, but we have to make a good checklist. And this is going to be different for every person in every environment, right? So the checklist, as a rule, should be simple. We should know if it's like how it's going to be used, when it's going to be used. It should be pretty short. It should only have the really important things on them. It needs to be visually simple and easy to use, and it needs to be worked. It needs to be utilized, changed, tested, and you have to get buy-in from the group that's using it in order for it to be effective. In the world of emergency medicine, the place that we've seen checklists come up the most is in the realm of airway management. So there's a handful of studies, kind of starting in the 2010s, that are fairly equivocal. So one of the first ones that came out showed that the intubation happened more frequently when they were using checklists, but it didn't change any other metrics of the intubation, didn't improve outcomes necessarily. They also have seen that it didn't really affect adverse events during intubation, that there was no, there were the same number of desaturations or hypotensive events. And the use of a checklist did not improve the incident of other serious adverse events. This was a pre-hospital study in a HEM system, and when they didn't use the checklist, scene times were shorter. That all kind of makes sense. The kind of kicker is that I think it still helps. So despite all of these meta-analyses, these studies that have focused on really discrete outcomes, it's to some extent misses the forest for the trees. This is one of the more recent studies that looked at a simulation environment, and what they found is that when their providers who are trained in using a checklist used a checklist, there were fewer tasks that were clinically important that were omitted or forgotten. So basically, when you use a checklist that has been made and is appropriate to your environment, you miss fewer things. So let's take, for example, having a blood pressure cuff that's cycling on the side of your like fluids or your IV. That is not necessarily going to affect your desaturation events. It may not affect your first airway, first pass success, but that is a clinically important consideration to have during the management of your airway that's not going to be captured by those other studies. And part of that is that you really need it to be appropriate to the environment and applied by your people in order for it to make sense. And that can be hard to do. We know that providers really need to feel like they're involved in the process in order to be compliant with the checklist use. So what does this look like? Well, in the hospital, the first attempts at using checklists were really kind of clunky. This was one from the MCRIT guy, Scott Weingart, that is really very busy, not very effective in terms of the things that we're talking about and being simple and straightforward. So we learned from that. This is an example of a checklist used by a Sydney helicopter EMS crew that incorporates the checklist on a mat that they roll out, and they put all of their gear on that mat in certain places so that they're not only sure that they have all of their stuff, but then they can run through their checklist at the same time. This was another iteration of a kind of more recent iteration of Scott Weingart's, the MCRIT guy, doing an in-hospital checklist where he kind of breaks it more into chunks. It's more straightforward. He's looking at patient-centered issues, gear-centered issues, and then kind of team-centered issues. And I think that this is getting closer to what we need in our pre-hospital environment. So here's an example of something that Boston MedFlight uses, where they've got their patient factors. So are they hypotensive? Are they pre-oxygenated? Have they positioned appropriately? Their monitors on, etc. Do they have their equipment? And then they make sure their team is ready. And this is very similar to the approach that I've taken when I've made checklists for myself in the different environments that I've worked. And this is an example of the one that I used in residency, where I made sure the room was ready. We had kind of the left side of the screen here is my more slow checklist. So we're talking to the team, we're assigning roles, the individual makes sure that they're ready. We move to the patient, we make sure that we've addressed what some people call the HOP killers, the hypotension, oxygenation, and the pH or the acidosis, the things that can kill us on induction when we're using RSI. We've looked at the positioning, and then we've got all of our equipment ready. And then once all of that has happened, that can be slow, that can be that ramp up process. Then we have the brief check-in immediately before we go, right? We want everyone to be on the same page. We want the room ready, and we want to kind of create a realm of psychological safety where everybody is comfortable with the plan, everyone has an opportunity to voice concerns, and then we can focus in on the task at hand and do the intubation. For the pre-hospital room, this is the checklist that I've been carrying with me as a fellow, and we've not done an RSI in the field yet, but I've broken it up in the same way and tried to make it so that I could hand this to anybody in the ambulance and they would be able to use it. And we could read it through together and really be sure that our environment is ready to manage that airway, that there's no questions about whether or not we have addressed all of the most important patient-centered issues, and if we have all of the most important equipment and kind of team readiness factors that we need to be sure are known not just by the person who's doing the airway, but by the group as a whole. And I think that is the thing that I want you to consider is like what makes sense for your environment. Obviously, in Maine, we're not doing RSI, but there are times when you're going to be managing an airway and you need to be very deliberate about the actions that you're taking, the considerations that you have for that patient, the equipment that you're using, etc. In creating a checklist that focuses on your equipment, your environment, your team, the people who might be there, and the factors that you find are most important in that realm, is really going to be more useful to you than me telling you this is my checklist. I think you should use it, right? Like the resources and equipment available in the city of Portland are not the same as in Upper Kennebec Valley, right? Like those are wildly different environments, and I'm not going to presume to know what the right answer is for folks in that different environment. So altogether, how do we consistently and expertly manage airways in difficult environments? Well, I think it starts with knowing how to do the basic things really well. We know how to position, we know how to suction, we know how to use our adjuncts, and we know not only how to ventilate, but when to ventilate and how to ventilate well. We'll have game plans for certain situations. We'll know when to jump to the supraglottics. We know when to be looking and feeling the neck early, whether that's burns, facial trauma, or in CPR. And then I want you to consider checklists. I don't think you need to use one if it doesn't make sense for you, but I want you to think about what would make sense for our environment. When do I feel like I could use a reference that would help offload my brain and, put some things on paper that make it easier to just run the process, hit all the points, and do the thing that I know is going to be hard, do that well every single time. I will send you my references should you be so inclined to read them. Or if you just want any of the papers or the evidence, I've got the PDFs kind of at the ready. And this is my email, and this is my personal cell phone number. Please feel free to reach out to me with any questions, concerns, heckling, etc. And I know that Eric would be thrilled if you would scan this QR code and fill out an evaluation of our program. I believe, Eric, give me a nod if it's anonymous.
It is.
Yeah. Okay. So feel free to speak your mind. We want to be able to do this well, do this better, get you education that is useful. And I will put this screen back up in a second. But the other thing is we do have another one scheduled for June 18th, and this will be the QR code to register. So I'll leave this up for a minute. If there are any questions, I'm happy to start taking those. And yeah, Eric, anything else that you'd like me to add?
Thank you for doing this today. You did a great job. We do have a couple questions in the chat, and I believe Matt will be able to read them to you if you'd like to answer them for us.
Sure.
Yeah, Jack,
Matt could just answer.
One of the questions came early on in the lecture where you were talking about keeping a patient in a more upright position. And Joe Bruschetto asked, how would you do this in the context of chest compressions?
Oh, wow. That is a poignant question. The answer is that we don't. So this was a big thing. I don't know, Joe, if you were kind of privy to the conversation that happened, October of this year. There was some kind of back and forth from one of the fire chiefs associations that was kind of advocating for being a proponent of heads up CPR, which is strapping a Lucas device on a patient, elevating the head of the bed, and then doing CPR with the head of the bed up. And the idea is that it improves venous drainage from the head and neck back into the chest and might improve neurologic survival outcomes. But we just don't have good evidence for it. And in the scenario of CPR, I think the thing that's important is that the priority becomes circulation, and that's the CABC, right? It's our focus on high quality chest compressions. And airway management kind of actually falls second to that in that environment. And then maybe I answered the question kind of in the rest of the talk where I would just drop a supraglottic if you have a provider who's capable of doing that, and that'll help solve that issue for you.
Thank you for that, Jack. There was another question, or Eric put a note in the chat. If your name is partial on the list of attendees, if you'd like credit for this, please give us your full name. Or if you can't do that because you're joining by phone, please email eric.wellman, WELLMAN @mainhealth.org with your name and your license number, and we can get you CEHs for this. Another question came up that asked, will we be able to listen to this again? Will there be a link? And the answer is yes. We're working on the mechanism of that, and we have all of your email information. We'll send you that link when we are done.
Cool. Let me, I'll advance to if anyone wants to try that QR code to be able to sign up for the next talk.
We really thank you all for being here today. We're really excited about this opportunity to interface with everyone and get a chance to work with everyone on a regular basis. We're excited about this idea that our colleague and resident Joe Minichiello brought up to us, and we're hopeful that this will take off and become a regular part of the dialogue between the Maine Medical Center EMS division and all of you. This is the next opportunity in this lecture series. Jack, I'm going to take over and show the other opportunities that we have during EMS week, if you don't mind.
Absolutely.
We're doing something a little bit new this year with EMS week here, and we're actually spending a little bit more energy on learning opportunities together. And this is another opportunity that we wanted to share with you all. On Friday at 1 to 2 p.m., we have a hybrid meeting, an in-person meeting in Dana 2 that will also be streamed on Teams for those who can't make it in person. We titled this early on hot topics, but what we're really going to cover is thematic to EMS week this year. The theme, if you haven't heard, is honoring our past and forging our future. We're going to use that to talk about time critical illnesses and where we've been in the recent past around our STEMI and stroke system, and then also looking ahead to other systems of care that we're in the process of thinking about and considering. So anyone interested, that's another free opportunity on Friday of this week. We have a couple other activities going on in and around the medical center. And if you happen to be coming to visit us, please stop by the EMS room during the breakfast, lunch, and dinner times. There'll be food there all week long that we're excited to share with you all and celebrate with you. Couple last minute things. We're again hoping to have more of these types of opportunities. Keep your eyes out. We're going to try to find a standard time. Our next one, as Jack mentioned, is on the 18th of June, and we'll duplicate that moving forward. We're going to talk in July, we think, about sepsis, and then more future topics. If there's a topic you're interested in, please reach out to let us know, and we're happy to build that into the sequence. I think that's it. Eric, Jack, any last minute thoughts you guys have?
Thank you all for coming, and happy EMS week.
Yeah. Thanks, guys. Feel free to reach out. Always happy to chat.
Thank you all.